Check. Check one, two. Check, check. Check one, two. Check, check. Check, check one, two. Check, check. Check one, two. Check, check. Check one, two. Check, check. Check one, two. Check one, two. Check one, two. Check, check. Check one, two. Check, check. Check one, two. Check, check. Check one, two.
I'm Yenshin Chen from MD Anderson in Houston, Texas. Thank you for joining us.
I'm Javier Melchor from National Cancer Institute in Mexico.
So our first presentation is Dr. Annelies Surge-Meijer from Academic Medical Center, presenting on routine sampling of lymph node station 16B19 and 8A during pancreatoduodenectomy.
So thank you very much for the introduction, and I'm happy to tell you something about lymph node station 16B1 during pancreatoduodenectomy for patients with pancreatic cancer and periampullary cancers. So as we all know that there's a very poor survival in patients undergoing pancreatoduodenectomy for these type of cancers. And lymph node involvement is an important prognostic factor. However, preoperatively on imaging, it's difficult to establish or to examine the lymph node involvement. So the ICPS in 2014 made up a standard lymphadenectomy during pancreatoduodenectomy. And lymph node station 16B1 was not in there because there was no consensus found because of conflicting literature and different expert opinions. Lymph node station 16B1 is located para-aortic between the inferior vena cava and the aorta, below the renal vein. But there is some evidence that lymph node 16B1 involvement is associated with poor survival. In PDAC, it ranged between 5 to 17 months when you look at patients with lymph node 16B1 involved, compared to patients who don't have it involved. So there was no consensus because prospective studies are lacking, and especially in the patient group of periampullary cancers. And that's why we aim to determine overall survival in patients undergoing pancreatoduodenectomy for pancreatic cancer and periampullary cancers, and looked at lymph node station 16B1. The primary endpoint was overall survival, and secondary endpoints included prevalence of metastasis to lymph node station 16B1 and 3-year survival probability. So we conducted a prospective observational cohort study in 7 centers in the Netherlands, and we included patients undergoing pancreatoduodenectomy for PDAC, distal cholangiocarcinoma, ampullary cancer, and duodenal cancer. The lymph node station 16B1 was harvested during pancreatoduodenectomy and sent in separately for histological assessment. We included 511 patients, and there was a metastasis rate of 13% in these patients. When we look at the baseline characteristics, we noticed that preoperative therapy, chemotherapy and chemoradiotherapy, was mostly given in patients with pancreatic cancer, as compared to the other cancers, as well as adjuvant therapy, which is in line with current Dutch practice. And when you look at the overall survival, the blue line indicates the patients with without any lymph node involved, so N0. The red line indicates patients who did have lymph node involvement, but not 16B1. And the green line, which is the worst survival, are the patients that had lymph node 16B1 involved. This is for all diagnoses. And when you look at the specific diagnosis, the red line indicates the patients that have lymph node station 16B1 involved, and the blue line indicates the patients who didn't. But the blue line patients could have other lymph nodes involved. We saw worse overall survival in all diagnoses. Pancreatic cancer, this one shows the distal cholangiocarcinoma patients, ampullary carcinoma patients, and duodenal carcinoma patients. So it was significantly worse survival when lymph node station 16B1 was involved. When we look at median and 3-year survival rates, you see that in pancreatic cancer, there's a 3-year survival rate of 35% if lymph node 16B1 is not involved. 45% in patients with distal cholangiocarcinoma, 61% in patients with ampullary cancer, and 70% in patients with duodenal cancer. And when you look at the patients that did have 16B1 involved, there was strikingly worse 3-year survival rates of only 5% in patients with pancreatic cancer, 0 in patients with distal cholangiocarcinoma and ampullary cancers, and 29% in patients with duodenal cancer. So there are some limitations to this study. We did not perform intraoperative frozen sections, so we could not take information on that into account. Furthermore, we could not include information about the aborted patients that, there was no information on those. And adjuvant therapy was not routinely given in other diagnoses than pancreatic cancer. However, based on the results of this study, we can conclude that lymph node 16B1 is associated with very poor survival in all diagnoses we included for this study. And there is a role for routine intraoperative sampling. However, what are the consequences? And that, I think, remains a topic of debate. Would you then abort the Whipple operation? There are some patients that already have like a longer survival, so there are patients that do benefit from it. So I think we need to look further into that. And we also need to look further into patients that had systemic therapy. And that was my presentation. Thank you very much for your attention. Be happy to take any questions.
This paper will be discussed by Dr. Rebecca Snyder from MD Anderson.
Thank you very much. That was very nicely presented and great work by the Dutch Pancreatic Cancer Group. I just have 3 questions for you. The first is, the total cohort was 1,200 patients, and then you had information on this lymph node for 500 patients. So do you have information on how that decision was made to resect that lymph node in those patients? Did any of those patients have evidence of lymph node involvement by imaging preoperatively? Was it based on surgeon preference, or was there something seen in the operating room that looked grossly abnormal that led to resection of that node? The second question is, do you have any information about recurrence patterns in the patients who had resection of that lymph node? Was it local, regional, or particularly distant recurrence based on what we're seeing in terms of survival? And then finally, you touched on this a little bit, but kind of how should we apply these? I think most of us would say if we see imaging preoperatively that suggests that that node is involved, we would confirm that and then not offer that patient surgery. So would you advise that this should be approached similar to gallbladder cancer, where it's recommended that this is done at the beginning of the operation, routinely set for frozen? If positive, then the resection is aborted. Thanks again.
Thank you so much for your questions. As for the first question was about how I think why. So if I'm correct, your first question was about, can you repeat it? Sorry.
How were the patients selected for resection of that?
All right, yeah. So the selection was in the 7 centers that were including the patients. We do resection for patients with resectable and borderline resectable disease. We do that on preoperative imaging, but there was no information on lymph node 16B1 on preoperative imaging that we could include for this study. But it would be very interesting to look into those details further. But then we need to obviously get all the scans from the other centers, which I think would be a great contribution to the study. And the second question, sorry, I didn't write it.
About recurrence patterns.
Oh, yeah, the recurrence patterns. So the most of the patients that died was because of recurrence. And we didn't take information into account on which pattern, so local recurrence or distant metastasis, because we just looked at survival. So I cannot give you any information on those patients, unfortunately.
And then the last question was just about whether you would recommend sampling that at the beginning of the operation and then using that to guide whether or not to proceed.
I think that's a very interesting question. I would recommend to actually sample sample it during at the beginning of the operation. Some centers I know already abort the operation, but there was no really a consensus. I think that this study shows that there's very poor survival, but then again, the groups are not as that large that you can, and there are also patients that actually survive longer than a year. We looked into those patients, and they were a little bit younger and they got adjuvant therapy more often, but we couldn't really make a clear statement on that. But I would advise to sample it during pancreatitis the next meeting. Yes.
Papers open for questions. Please state your name and your institution.
Mihir Shah from Emory. Great work. So quick question about the involvement of hepatic artery lymph node, if that was correlated with the involvement of 16B1 lymph node. Because, there are some studies that are showing that involvement of hepatic artery lymph node, in addition, adds a worse prognosis for these cancers. I mean, in my mind, there's no doubt that this is stage 4 cancer and the survival is for stage 4 cancer.
Well, we did look into it. Thank you very much for your question. And we couldn't find an association on those lymph node stations in this group. As for the sampling, we didn't have of all the patients that a specific lymph node station information on that specific lymph node station. So we couldn't find it in this study. But we did look into it.
Scott Helton, Virginia Mason in Seattle. I would just add a word of caution until there's further data demonstrating that it's really prognostic, because dissection in that area, while it's simple, is associated with a higher chylous sleep rate. It might be very interesting to look at this cohort of 500 patients to see if you have any evidence of that. So, I mean, that's where the main lymph channels are running, is right through that area. And we don't typically dissect in that area, right? Particularly if there's nothing pathologic by palpation.
I think that would be very interesting contribution to this work. I'd be happy to talk a little bit further on that with you.
Thank you.
Thank you.
Our next speaker is Alexander Mancela from Rogers University. The talk is, did COVID-19 disrupt surgery for patients with pancreatic and hepatic malignancies? Thank you.
All right. Thank you. My name's Alex. I'm a general surgery resident at Rutgers. These beautiful people are surgical oncology department and everyone who worked on this project with us. We have no disclosures. So as everyone is well aware, COVID-19 significantly disrupted the US healthcare system, and this included elective operations and systemic therapy regimens starting in about March 2020. In the beginning, especially in New Jersey, state government published emergency legislature that halted all elective operations. As time went on and these restrictions were eased, multiple surgical and medical organizations published guidelines on who could have access to elective surgery, what patients should be prioritized, and how do we conserve hospital resources. So it's likely that oncologic operations were prioritized during this time to avoid the risk of disease progression. So the aim of this work was to evaluate if there was the disruption of the US healthcare system affected pancreatic and hepatic operations for malignancy. So we use the Vizient Clinical Database. This is a proprietary national database that gets data from across the nation from 97% of academic medical centers and over 100 oncologic hospitals. We look for inpatient pancreatic and hepatic operations using ICD-10 codes for diagnosis and procedure. We then broke this up into a pre-pandemic period from March 2019 to February 2020, and a pandemic period from March 2020 to June 2022. For analysis, we used control charts to look for changes in trends over time, and we also did students t-test and Wilcoxon rank sum to evaluate the difference in mean operative volume for the pandemic and pre-pandemic period. This is an example of a control chart on the right. These are traditionally used in quality improvement. You can see time plotted on the x-axis, and the y-axis is number of events, and then data points are plotted in blue. The software then looks at the distribution of the data and determines the mean, which is labeled as CL, the center line going through the middle, and then the UCL and LCL, which are the red horizontal lines. And these are the upper and lower control limits. And so these are analogous to standard deviations. The software then looks at this data, looks at the control limits associated with it, and then it'll label points that are considered statistically significantly deviated as red diamonds. There are two ways that points can be considered deviated. One, in the first circle there, they could be very far from the mean. Or two, in the second circle, you can have a group of points that trend together, and they might not have to be as far from the mean if there's more of a consistent trend. So we had 27,900 patients over 40 months. 63% had pancreatic malignancies that were undergoing pancreatic operations. And then 25% underwent hepatic operations for primary hepatic malignancies, and 11% had hepatic operations for secondary malignancies, specifically colorectal mets. This graph shows our number of monthly pancreatic operations for pancreatic malignancies across the United States. Once again, time on the x-axis going from March 2019 on the left to June 2022 on the right. Red vertical line at March 2020 is the separation of the pre-pandemic and pandemic period. And then we've got the operative volume on the y-axis. And the first thing you'll notice is that there's a group of 6 months of red diamonds about a year into the pandemic. These represent a statistically significantly increased volume of operations, but clearly trends back down towards the baseline. And then the data points return to blue. So this tells us that there was a transient increase in the number of operations for a period of 6 months that then normalized to baseline. This is confirmed by the p-value of 0.208, which tells us that the pre-pandemic mean operative value and the pandemic mean operative volume are not different from each other. This is our primary hepatic cancers undergoing hepatic operations data. Same setup, x-axis is time, y-axis is operations across the United States. And here we have a different pattern. Immediately following the beginning of the pandemic, we have 4 months of statistically significantly lower operative volume. But then after August, returns to normal. We can see that the trend overall after that point stays at about the same level distributed around the mean center line. And that's confirmed by the p-value of 0.224, which tells us that the pre and pandemic periods had roughly the same average operative volume. And this final one is our hepatic operations for colorectal mets. And in this instance, you can see that there are no red diamonds anywhere on the chart. This tells us that there were no statistically significant deviations that were outside of the expected parameters. This is confirmed by the p-value of 0.113 that shows us that the mean operative volume didn't change. So with any database work, the first limitation is always the use of coding. And then we have 3 specific limitations based on the Vizient database. The first is that inpatient operations are coded using ICD-10 procedure codes. And this is not how most operations are recorded in the hospital, instead using CPT codes. And the translation between the two is not always very clear. So there's not always a very clear answer to what ICD-10 code correlates to what CPT code. Then we have some oncologic data, but we really lack the specific and detailed level of oncologic data that you can get from things like the NCDB. And we also have limited clinical outcomes data. And so the 3 of these provide the future directions for what can be done next, especially as time goes on and more data becomes available about the pandemic. Future studies can look with more precision at what types of operations were prioritized, what types of neoadjuvant therapy were utilized, what other procedures were performed, and take more information about staging, time to recurrence, and overall mortality and outcomes. So we saw that pancreatic and hepatic operations for metastatic colorectal cancer were relatively unaffected by the pandemic. We also saw that hepatic operations for primary liver malignancies transiently decreased early in the pandemic, but then bounced back. So overall, among the 3 populations, we didn't see any change in the mean operative volume in the pre-pandemic and the pandemic periods, showing that the overall baseline rate was relatively unchanged. So with this in mind, we think that the surgery for pancreatic and hepatobiliary malignancies was prioritized during the pandemic. And further studies should focus on the three issues we talked about earlier: more detailed operative information, more detailed oncologic information, and more detailed outcomes information. Thank you, and I'll take questions.
This will be discussed by Mir Shah from Emory University.
Thank you, Dr. Manzella, for sending us slides in advance. Great work. It's important and encouraging to know that the HPB volumes were not decreased during the pandemic, despite such a devastating event for the world. One important question comes to my mind is, I see that you've collected data from 2019 onwards.
Mhm.
And when I look at the data, did you see or did you collect data on anything prior to 2019 to see how the yearly trend in HPB cases are? Because if the yearly trend is to increase, there's an increase in HPB cases, and after 2019, that 1 year it did not, it increased more and then it just remained the same. And that's still a relative decrease during the pandemic. And my second question is, have you compared this data to your own institutional data to see how the trends are at your institution?
Yep, absolutely. So in terms of prior data, the data capture for Vizient is increasing every year, but as we go back by about 3 or 4 years, we start to have significantly lower rates of data collection for specific variables. That being said, Dr. Pitt has been tracking mostly the pancreatic data, but hepatic as well in NSQIP going back at least 10 years. And based on discussions that we had on the NSQIP data, we believe that the past 5 years prior to 2019, the rate of increase was nominal. Although operations are increasing over time, we believe that the plateau that we see in 2019 is relatively stable for the years preceding that. And then for the second question, we do have a separate project that focused on our institutional level data. And we saw similar trends where overall operations proceeded during the pandemic for our surgical oncology department. And then they're working on developing or gathering more specific outcomes-based data on their patient population that we'll work on in the future.
What do you think about the accuracy of the data? Because you had far more pancreatic operations followed by primary liver, and then secondary liver was last, which isn't always true across the board.
Yeah, absolutely. So we came up with the list of codes that define these operations by testing them against our own institution and confirming them in the electronic medical record. So that being said, we know that there are going to be cases that aren't captured correctly. And we're still in the process of figuring out how good our capture is. I think the estimate for the NSQIP capture was around 70% of cases, and we're probably a little below that. But the advantage to this data set was to kind of get in early while the data is being produced more rapidly, and then we can follow up with more in-depth studies with higher capture rates after we kind of got a foothold in.
Thank you, Dr. Mancilla.
Thanks.
The next presentation will be Dr. Aslam Ijad from Ohio State University, the impact of persistence of poverty on hepatopancreaticobiliary cancer.
Thank you today, HPBA, for the honor of the podium. I'll be presenting this on behalf of Dr. Lima, who unfortunately was not able to make the meeting. We have nothing to disclose. So the burden of HPB cancer mortality may be particularly high among patients facing adverse social determinants of health, as environmental factors can drive inequities in patient health. Previous research from our group has shown that metrics such as the SVI has been associated with more fragmented care and worse outcomes following surgery for patients with HPB cancer. While social determinants of health have been associated with lower rates of screening and later stage of diagnosis for several types of cancers, these disparities persist even among patients with early stage disease. We previously found that individuals living in areas with poor income, higher rates of unemployment, or lower education levels resulted in lower odds of receiving curative intent surgery compared with patients living in more affluent conditions. The sociodemographic index, which combines information on the economy, education, and fertility rate of countries around the world, has also been associated with disparities in mortality after surgical resection for HPV cancers. Hence, despite improvements in the multidisciplinary care, disparities in access to optimal HPV cancer persist. Measures of inequity in cancer outcomes, such as income, insurance status, and educational attainment, have previously been assessed at the individual level. More recently, however, there's been an increased attention on the entire physical and social environment in which a patient lives and how an individual's lived experience may affect their outcomes. For example, patients living in counties with persistent high unemployment rates, lower quality of education, inadequate housing and nutrition, and a lack of basic public services, and as well as being exposed to pro-carcinogenic risk factors, are less likely to receive access to high volume treatment facilities. Furthermore, counties with persistent poverty are more likely to have poor infrastructure and can contribute to a higher likelihood of experiencing fragmented care that can lead to worse outcomes. In patients with non-small cell lung cancer, breast cancer, and others, previous studies have shown that persistence of poverty results in lower cancer screening rates and higher cancer-related mortality. Thus, the objective of the current study was to define the impact of the persistence of poverty on access to care and cancer-specific outcomes among patients diagnosed with hepatopancreatic and biliary cancers. In addition, we sought to characterize the relative association of county-level poverty duration and patient race and/or ethnicity on individual-level HPV cancer outcomes. To do this, counties were stratified according to the proportion of individuals living below the federal poverty level for each decade based on definitions by the U.S. Department of Agriculture. The cutoff of 19.5% was based on the recommendations of the Congressional Research Service. Patients were then categorized in 3 categories: living in a county that never experienced high poverty from 1980 to 2010, intermittent high poverty from 1980 to 2010, and persistent poverty from 1980 to 2010. The primary outcome of the study was a textbook outcome defined as the absence of postoperative complications, prolonged length of stay, and 90-day readmission and mortality. Cancer-specific mortality was also defined as alive or other cause of death versus cancer-related death. Patients diagnosed with hepatocellular carcinoma, ICC, ECC, gallbladder cancer, and PDAC were analyzed. Approximately half of the cohort was diagnosed with pancreatic cancer, approximately a quarter with hepatocellular carcinoma, and a mixture of the rest. This is a heat map of county-level poverty across the United States. Poverty categories that were not captured are depicted in grayscale. Among the 41,077 counties, 83% were never high poverty, 12.7% were intermittently high, and 4.3% were persistently high, or persistently poverty. These counties were overwhelmingly rural and located in the South, as you can see here on the map, with a higher proportion of minorities and non or underinsured patients. Now, for the results for surgery, although persistent poverty was not associated with diagnosis of early versus late stage of disease, individuals residing in persistently poverty counties demonstrated lower odds of undergoing surgical resection for early stage disease with an odds ratio of 0.82. Among patients who underwent surgery, persistent poverty counties were considerably less likely to achieve a textbook outcome with an odds ratio of 0.54. This difference was similar in patients living in intermittently high poverty counties with a 10% and 20% likelihood of undergoing surgery for early stage disease and achieving a textbook outcome respectively. This figure depicts the probability of receiving surgical resection across poverty levels by race. And as you can see, compared with non-Hispanic white patients, non-Hispanic Black patients had lower odds of undergoing surgical resection with increasing levels of poverty. Notably, white patients in persistently poverty counties still were more likely to undergo resection versus non-Hispanic Black patients in this cohort. In terms of survival, patients living in intermittently high and persistently poverty counties had a higher likelihood of dying within 5 years of diagnosis. compared with patients living in never high poverty counties. Further analysis illustrated correlation between poverty and survival among a different subset of patients. For example, patients residing in intermittently high poverty counties and persistently poverty counties had increased risk of death regardless of their disease stage at diagnosis and regardless of whether or not the patient underwent surgical resection. Across different poverty cohorts, 3-year and 5-year overall cancer-specific mortality progressively decreased with longer exposure to poverty from 16.1, 13.6 to 13.1%. And finally, though increasing poverty levels correlated with worse overall survival, non-Hispanic Black patients had a higher risk of death compared to non-Hispanic white patients. So in conclusion, persistence of poverty was associated with a lower likelihood of receipt of surgical resection, achievement of a postoperative textbook outcome, and worse cancer specific survival. Racial disparities were noted across different categories of poverty, and non-Hispanic Black patients were at particularly higher risk of suboptimal outcomes. Future policies that target improved structured social services to counties with long durations of poverty are needed to promote a more equitable healthcare system. Thank you.
Dr. Helton.
Thank you very much, especially for pinch hitting. You did an excellent
Thank you.
job. I don't know what degree your involvement was, but this is just another excellent study that comes out of Ohio State, and under Dr. Pollock's direction, it's been a major mover in this area. So I have a couple comments and just two simple questions. It's well known that race and social economic status are determinants for healthcare outcomes in patients with cancer. That's been studied and noted for quite some time. This study, despite the limitations that we all know about that exist with this here administrative data, demonstrates that patients with HPB cancers who live in impoverished areas, defined as persistent poverty, have worse outcomes, and that non-Hispanic Blacks, as you just said, fare worse than whites. It's just another sad fact about our healthcare system. This disparity in outcomes tied to poverty is, as you said, probably related to decreased access of care. And the bummer is there are recent disclosures that suggest that this problem is just going to get worse because the giant conglomerate healthcare systems are shutting down their facilities and their clinics, specifically in impoverished areas, and building new facilities in more affluent areas. So this access to care is only going to get worse for those that are living in impoverished areas. So I have two questions. One is, how can your data influence or be used by policymakers, as you said in your last statement? How is it going to be used to bring about change for good? That's my first question. And the second is, I think you analyze your data collectively, and I'm wondering if there's enough power in the database so that you can look at a more granular level at the impoverished areas to see if there are hotspots where the care is or the outcomes are even worse.
Mm-hmm. Great question. For the second one, that's an easy one for me just because I don't know. You know, that's something that we can certainly look at. I would assume so, that there are these hotspots that have worse care. First question is more challenging, obviously. I think there are a number of different strategies that can be utilized. Like you said, hospitals are closing down access or closing down facilities in these rural areas. On top of that, regionalization for HPB cancers is becoming more prominent. I think I heard a comment the other day that in 10 years, you know, Whipple won't be done in any rural areas, and that'll just make access worse. So what can we do? A number of things. I think education, personally, I think education for both the patient and the providers, so they can understand the type of care or the high quality care that they need to seek. By educating providers on signs and symptoms, early diagnosis, potentially we can diagnose these cancers earlier and potentially provide curative intent surgery. In terms of the actual surgical resection, yeah, that's a tough one. I think there's definitely a shortage of physicians providing care in these areas. I think we have to support the communities in order to either bring the care to them or bring them to high volume centers and to get these high quality care done. In addition to that, kind of what we showed, the structure around these communities, there's been a lot of research on food deserts, for instance, and other supportive situations that just aren't there in these communities. And that all adds up to why these patients are doing worse. So, again, tough problem. I think there are a lot of things that we can and should be doing.
Thank you.
Thank you.
Papers open for discussion.
Yeah, Millis, University of Chicago. Terrific talk and really important data. So, however, I think it may be the lack of granularity probably hurts the case. So, for instance, my county, Cook County, has the Gold Coast and it has the South Side.
Yeah.
And certainly the South Side would be your permanent poverty and the Gold Coast is not, but overall Cook County gets a pass or whatever, right? So then when you start looking at the racial differentiation, you're probably getting more, unfortunately, into the level that is granular enough to make some recommendations, hopefully. Secondly, there are databases that look at zip code and even neighborhood type data that might help in helping you determine what you could suggest, right? Third, I just got to say that, you mentioned that in 10 years, someone said that Whipples wouldn't be done in the rural community. I would say, I would make that a challenge to the society and say that cannot happen.
Right.
We have to have access, with good quality surgeons and surgical systems and all these, not all, but enough of the areas that we are able to capture and provide good care to them. So it's a challenge to this society to make sure that your statement doesn't happen. So I'm not sure there's any questions there. I'm happy to hear your comments and thoughts on some of those.
Yeah, no, thank you. Thank you for that. Wonderful comments. And yeah, other than me completely agreeing with you, there's not much more to say, but I think, yeah, clearly access is an issue. And I think you're right. The society as a whole needs to take this problem on and come up with innovative ways that we can provide high quality care in these areas. Again, quality has also been looked at in these areas and not only the access, but the quality is also an issue. So I think we have a real opportunity here.
Thank you.
Thank you.
Our next speaker is Hassan Aziz from University of Iowa Hospitals and Clinics, and the topic is cleansing pancreatic surgery experience in general surgery residency in the US, 1990-2021.
Thank you, everyone, for the privilege of the podium. Thank you for accepting this paper. I have no disclosures to make. So, as we all know, general surgery training in the US is undergoing many challenges and many changes. There's a lot of data that shows that there's decrease in variability of the overall operative volume for major cases. The average case numbers for chief residents who are graduating is declining. We have seen this for thoracic cases, trauma cases, and vascular cases. There are data that abdominal surgery operation volume has, however, increased in general surgery training. When the COVID-19 hit, we did a study to assess how the COVID-19 had affected general surgery residency experience, and we found that there was a decline in operative volume and increase in didactics. Of course, this was a survey study and a perception from surgery residents at that time. When we look at hepatobiliary surgery experience, for a general surgery resident, it's not HPB, it's basically B, which is biliary. And if you go into the depth of B, it's basically cholecystectomy. And if you go into the depth of cholecystectomy, it's basically laparoscopic cholecystectomy. There is evolving data that many residents may graduate even without doing an open cholecystectomy. So we thought to see how this is affecting pancreatic disease, especially because pancreatic disease management has evolved during these years. For example, now we have IR, we have GI, and we are having an increased specialization in HPB fellowships. So we utilize the ACGME database. It's a national case log of general surgery residents case logs from 1990 to 2021. They have the mean data and the median information for total pancreatic procedures. They'll give you the 10th, the 30th, the 50th, and the 70th and 90th percentile of these cases. Now, pancreatic procedures that are defined in the database are distal pancreatic drainage, Whipple's, and drainage of pancreatic abscesses. We also utilize the database to assess the number of graduating residents every year. The aim of our study was to assess the trends in resident performance of pancreatic operations. We hypothesized that there would be a decline in pancreatic surgery volume in general surgery residents. This is a snapshot of what the database looks like. So you'll get the surgeon chief. This is basically a PGY 4 or PGY 5 doing these cases. Surgeon junior is a mid-level resident. And then it gives you an average value and a maximum value. For example, if you look at this, this is a snapshot of actually mine. So you will look at pancreatic Whipple cases done around mean would be 4.6 for a total volume for a graduating resident. So this is the data. The x-axis represents the years, and the y-axis represents the mean. As you can see, there was an increase in the mean pancreatic cases done till the year 2005, 2007. After that, there has been a decline in the total pancreatic cases done by a graduating chief, by a surgeon junior, and overall in totality. Then we looked at the percentiles of residents who are able to meet the 90th or the 30th percentile. Basically, 30th percentile would be the minimum required according to the ACGME case log requirements. And as you can see, the percentiles are also declining over the years. Now, we went into an analysis of the distal pancreatic resections. We found a similar trend that the mean volume had declined from 3 to about 2.7 for the distal pancreatic resections after the year 2007. We looked at mean cases for pseudocysts, and the trend continues to decline as the other cases. We then looked at the cases for Whipple's. The blank spaces is the missing data, that the data was not available. But as you can see, after the year 2010, there has been a steady decline in Whipple's done by surgery residents. And this is the final slide in terms of the database of the residents that are graduating in the US. So you can see that there has been a rise since 2005. If you look at from 2005 to 2021, there has been a rise by 300 residents, and the case volume has not increased by that proportion. I conclude that general surgery residence volume for pancreatic cancer has declined significantly during the past decades, and beyond the scopes of this study. However, I think specialization, innovation, and have a role to play in these findings. I suggest simulations maybe can help in this challenging pancreatic procedures to help guide our residents in terms of educating in this field. Thank you, and happy to take any questions.
The discussant is Jordan Cloyd from the Ohio State University.
Yeah, thank you. Thank you very much. So congratulations, Dr. Aziz, to you and your team. And thank you for bringing this very important and contemporary data to us. I really have two questions for you, and I want to present them more kind of just general, get your general philosophical thoughts rather than specific detailed questions, answers to these questions. And the first is, I was hoping you could just put this data into some context for us. Looking at your own data, how does the numbers that you present relate to minimum case requirements for the graduating residents? Can you look at your data and see any difference in terms of centralization of cases? Are some residents getting more cases while maybe other residents are getting fewer, as reflected in the overall trends? And finally, what does that look like in terms of fellow case reporting? Is there any existing literature on that could complement these data? And then my second overall question is, in light of what you're showing in terms of the data, do we still think that case reporting equals competency? And is case reporting the best measure of best metric for measuring resident competency? And there's obviously a difference between logging cases and doing cases in competency, and especially given trends in minimally invasive surgery, which is very different educationally for open surgery. What are your thoughts on that? So two overall questions, put into context for us, and then what do you think about case reporting? Thanks so much.
I think the second question is a little easier for me to answer because if you look at the ACGME case log requirements, and if you go into the guidelines of the ACGME, case logs does not equal competency. This is basically a number of opportunities, if you may say that a resident was provided by a program, and that may determine program competency in the fact that they are allowing their residents to be exposed to a procedure. So I would just clear the notion that the case log does not equal competency. Regarding the first question, I think it's a harder question in the sense that the database did not allow me to assess the effects of centralization, how having other fellows on service played a role. But if you look at the other data in terms of learning curve, there is data that about for pancreatic cancer, pancreatic surgery, you need up to 50 to 60 cases for the learning curve. And there's a paper by Sachs in 2015, 2016, which showed that only about 24% of the graduating residents will be able to get to that learning curve based on that value. So in brief, I can say that only a minority number of residents may get to that number, which can correlate to a learning curve. But that's all the data I could find.
Motaskadan from Mass General. Great talk. It's always really important to look at these numbers so we understand what it is that we're doing. I personally think that general surgery residency needs a big overhaul. It's been like this for 100 years. The question is, do we need to start specializing earlier in residency? And that's where competence matters. And then the evaluations and the metrics that go with it. Your board exams, we focus on things like head and neck that you don't need to do if you're going to be a pancreatic surgeon. The second thing that I would say is that does it matter? I mean, yesterday we heard a talk by the medical student at the presidential plenary about how there's and we're overtraining HPB surgeons. So what is the problem with what we're seeing if the numbers are declining? Do you really want a general surgery chief resident who's done 10 Whipples to then go and say, well, I'm fully trained to do Whipples and I'm going to go ahead and do that, perhaps in a non-specialized setting or a non-centralized setting or something like that? Thank you.
Those are great questions, and I think regarding your comment that the surgery residency needs an overhaul, I totally agree with you. That's the extent to the answer to that. Regarding the second part, I don't think that by any means we're suggesting that these graduating chief residents should go in the community and do a Whipple on their own, but I do think there's a value to being exposed to a lot of these cases, how the nuances are, how a general surgery residents communicate over the phone with you. Hey, I got this guy with a head mess. For example, I'll give you my example. I got a referral from a general surgery trained board certified surgeon. It was a case for a bile duct injury, just a little different. And he told me he did not cut the bile duct. And when I asked him, how do you know that? He said, because the pathology report says cystic duct margin is negative. So the point that I'm trying to make is that we're not trying to say that they can do these cases, but I do think there's a lot of value to being exposed early on. And also, for these general surgery residents who are going to make the decision that they want to do hepatobiliary surgery cases or not, we may find that many residents may want to change their pathway while they're in a fellowship because they necessarily did not get the experience in residency.
Thank you, Dr.
Thank you.
Aziz.
The next presentation is Dr. Maximiliano Servina Rojas from Massachusetts General Hospital. Tumor size reduction and serum CA19-9 kinetics as metrics of resectability and response following neoadjuvant FOLFIRINOX in patients with pancreatic ductal adenocarcinoma.
Good morning. Thank you to the HPB for giving us the opportunity to present our work. I'm Maximiliano Servin Rojas, a research trainee at Mass General. Sorry about that. We have no conflicts of interest this way. And as we know, pancreatic ductal adenocarcinoma is an aggressive cancer that has high recurrence rates following pancreatectomy, even among those patients that have negative margins after resection. And on the other hand, neoadjuvant therapy is becoming increasingly utilized because of the survival benefits that have noted over clinical trials. And it has also been proposed that neoadjuvant therapy can act as a filter to select the best biologically fit patients for surgery, as patients that progress during neoadjuvant therapy will have been poor candidates for upfront resection. On the other hand, we have little data on objective predictors of neoadjuvant therapy response. However, some groups have examined several markers. Specific, Dr. Sai and Dr. Newhook and colleagues have demonstrated that serum CA99 has a predictive value, and this is a common and inexpensive test in PDAC. Other things that have been explored is imaging findings, especially changes in tumor size, as demonstrated by Perry and colleagues from MD Anderson. Therefore, our aim was to evaluate the impact of tumor size reduction and CA99 kinetics on resectability, pathologic response, disease recurrence, and overall survival. This was a retrospective study from the MGH Curative Intent Neoadjuvant FOLFIRINOX PDAC database, and the inclusion criteria was patients who completed 8 cycles of FOLFIRINOX and then underwent surgical exploration. We excluded all patients who did not finish FOLFIRINOX and patients who were serum CA99 non-secretors, and we defined this as patients who had multiple measurements below 2 units per milliliter. And of note, all CA99 measurements were on once jaundice was resolved. As I mentioned before, our main outcomes were resectability, as non-resected versus resected, pathologic response, and this was collapsed into a binary outcome to be able to fit it in the multivariable logistic regression. Disease recurrence was measured from the time of surgery, and overall survival was measured from the time of diagnosis. For CA99 measurement, we took multiple measurements throughout treatment. The first measurement was before neoadjuvant chemotherapy, then after neoadjuvant chemotherapy, and then after resection. And according to the change in neoadjuvant therapy, we grouped patients according to the response into normal to abnormal levels. Those patients that had abnormal levels initially and went to normal, and we will refer to these later in the presentation as normalized, and patients with persistently normal levels, and those with persistently abnormal levels. And additionally, patients post-operation, those that had normalized levels and then elevated levels after surgery were also analyzed. For tumor size reduction, We went with the largest diameter in CT axial plane, and we basically just calculated a percentage from the size before neoadjuvant chemotherapy and after neoadjuvant chemotherapy. For the multivariable analysis, we used multivariable logistic regression for resectability and pathologic response, and Cox regression for disease recurrence and overall survival. And I want to note that for these particular two, we just included the patients who were actually resected. In the end, we identified a total of 193 patients. 51% were female. The median age was 68 years old. Pretty much all patients received chemoradiation after neoadjuvant FOLFIRINOX. The median tumor size reduction was 21%. And according to serum CA99 kinetics, 44% of the patients had persistently abnormal levels. 43% normalized the CA99 levels. 12% had persistently normal levels, and 1% went from normal to abnormal. In terms of the NCCN resectability criteria, our patients were 50% upfront, 31% borderline, and 54% were locally advanced tumors. Of these 193 patients, 60% were ultimately resected, of whom 91% were R0 margins, and 44% had complete or marked response. Of note, as I mentioned before, this was collapsed into a binary variable. 4% had complete response and 40% had marked response. For our first outcome of resectability, this is a multivariable logistic regression model, and we identified that patients that have bigger tumors had lesser odds of undergoing resection. And on the other hand, increasing tumor size reduction was associated with higher odds of resectability. In terms of CA99, we noted that patients who normalized CA99 during neoadjuvant therapy were at increasing odds of resectability. In terms of pathologic response, we found that percentage tumor size reduction was associated with increased odds of marked or complete pathologic response. We did not find any statistical difference for serum CA9 kinetics. In terms of disease recurrence, we found that patients who elevated CA99 after having prior normalization during neoadjuvant chemotherapy were associated with increased risk of recurrence. And in terms of overall survival, we noted that patients, again, that elevated CA99 after prior normalization were also associated with poor survival. Here we are presenting the Kaplan-Meier curves on the right. You can see the curves for recurrence, and on the left, the curves for overall survival. I want to bring to your attention the yellow line, which is the patients who elevated CA99 after surgery. Patients who elevated CA99 after surgery had a median recurrence, time to recurrence of 6 months compared to 10 to 12 months on the other groups. And on your right, we can see the same thing where patients who elevated CA99 after surgery have a lower median survival of 21 versus patients who always maintain normal levels, which are the blue line on the top. Those patients' median survival was not reached. The limitations of our study is that it's retrospective and then susceptible to selection bias. It's single center. And we were also unable to account for external influences on serum CA99 levels, such as the presence of cholangitis or acute pancreatitis after surgery. In conclusion, tumor size reduction predicts resectability and pathologic response, but not recurrence or survival. And serum CA99 normalization predicts resectability, recurrence, and survival. The implications for our studies of tumor size and serum CA99 can be used to monitor response to neoadjuvant therapy and beyond. I would like to thank my mentors, specifically Dr. Kalan. And happy to take any questions.
This paper will be discussed by Dr. Calicia Clark from Medical College of Wisconsin.
So congratulations on presenting a really nicely done paper. I have a couple questions for you. So I think you discussed tumor size reduction specifically as it relates to predicting resectability. It appears all of these patients were deemed at some point resectable, which is why you had a neoadjuvant approach, I assume. But are we really measuring tumor size reduction, or did we actually mirror reduction in terms of the tumor vascular interface? Because I think that's one of the most predictive factors for resectability. So were you able to evaluate that within this cohort? The second question is that you excluded patients that were non-CA19-9 producers. And such a challenging cohort of patients. And I actually think that the radiographic findings in that cohort are probably even more significant, as it sometimes is really one of the only things that we can actually deduce in terms of response. So would it help to sort of look at this measure of tumor size change and also tumor vascular interface in the non-19-9 secretors to see if it is actually predictive as well? And then finally, can you tell us a little bit about the patients, the 40% of patients that did not make it to surgery? What were the ways in which they failed?
Thank you for your question, Dr. Clark. For the first question, we did not evaluate the vascular interface. We just limited to the size of the tumor before and after therapy, but I think it's definitely worth looking into it for future analysis. Regarding the second questions of non-secretors, we decided to exclude these patients because we wanted to avoid different stages of treatment in these patients. And pretty much one of our main hypotheses was serum CA99, but I completely agree that probably radiological findings, are probably predictive of different outcomes. And regarding the 40% of patients who were not resectable, usually at MGH, patients are evaluated during different time points. And as long as patients do not progress during neoadjuvant chemotherapy and finish FOLFIRINOX therapy, they're usually explored, because we can also offer those patients, in the case they turn out to be unresectable, we can offer them IORT. But most of these patients were patients who progressed to metastatic disease or did not manage to finish FOLFIRINOX. Thank you.
So elevation in CA19-9 after prior normalization, that had the highest hazard ratio for death. And all the patients received 8 cycles of FOLFIRI or FOLFIRINOX. So would you, based on your data, proceed with surgery before the 8 cycles, meaning go to surgery earlier and not give them all 8 cycles when they normalize?
I would think probably that's probably an interesting approach, but I would think what happens with these patients, and it's just like personal opinion, I think probably what happens when patients progress after surgery is probably that there is some kind of resistance to treatment or progression, or maybe occult metastatic disease. So I think probably what we have to do is probably trying to find better ways to identify which patients are going to progress early after surgery before taking them to surgery. Because I think probably those patients who progress really early within the first 6 months are probably poor candidates for surgery.
All right, thank you.
Thank you so much.
Our next presentation is from Ohio State University. It will be presented by Suraj Monsan. Is hepatic versus hepatic pancreatic surgeons. Does its subspecialization impact patient outcomes?
Thank you. I'm Mary Dilhoff. Dr. Mossam unfortunately couldn't be here, so I'm going to present on behalf of our group. We have nothing to disclose. So background, training for surgical residency, obviously a long history, and starting at in Johns Hopkins in 1889. And slowly, we have started to specialize and subspecialize. And we've seen this since the 1980s with all these subspecializations in general surgery. And all of us have been privy and can have witnessed the increased quality of care and patient safety that's happened with the subspecialization over the last, 20 and 30 years. The quality of care comes down to not only just hospital level characteristics, but also surgeon level characteristics. So our total hospital volume, procedure-specific hospital volume, academic designation, nurse-to-patient ratio, magnet status, occupancy rate, all go into our hospital level characteristics. And then, of course, surgeon level characteristics with our total volume of surgeons, our procedure-specific surgeon volume, fragmentation of practice, and then our surgical training and fellowship training. We all well know the Berkmeyer papers from 15 years ago, looking at hospital volume and surgical mortality, and then looking at surgeon volume and mortality, and how these interact is very important. In pancreas surgery and specifically, we know these are complicated operations with high morbidity rate, high mortality rate, and many unplanned readmissions. So we sought to, in this study, develop a surgery subspecialization index and quantify the degree of care team specialization and evaluate that impact then of that care team on patient outcomes. We looked at Medicare files from 2013 to 2017 and included patients who underwent pancreas surgery. They were obviously all over 65 in this database and enrolled in Medicare A or B. They were excluded if they had an HMO. And of course, if we were missing other data like the surgeon or other outcome data. So here's the index that was developed. It's the surgeon's pancreas volume over the surgeon's total hepatopancreatic volume, and then the hospital's pancreas volume over the hospital's hepatopancreatic surgical volume. So basically, you're looking at this surgery subspecialization and this hospital subspecialization to develop this care team specialization in pancreas surgery specifically. Our outcomes, we looked at postoperative complications, the length of stay greater than 75th percentile, the unplanned 90-day readmission rate, and 90-day mortality. And those we looked at and grouped those as the textbook outcome. Other things we looked at were failure to rescue, discharge disposition, and index admission expenditures. Statistical analyses, the SSI was categorized. We just grouped them in tertiles, the low, intermediate, and high. We then looked at the mixed effects logistic regression analysis and the random effect for hospital. We looked at the expenditures and then the predicted margins. Our patient characteristics, there were nearly 20,000 patients in the data set. They were on average 72 years old and a little over half male. 89% were white. The Carlson comorbidity index was 2, and the elective admissions were 89%. The distributions were relatively normal. You can see for both the surgeon specialization and the hospital subspecialization when we grouped those in the tertiles. The textbook outcomes, this you can see in there the 90-day mortality, the readmission rate, the extended, no extended length of stay, and no complications, and that goes for your textbook outcome. And these were better in the high rates significantly over the low rates, which you can see. When we start looking at these a little bit more specifically, the textbook outcomes, you are more likely to have a better textbook outcome in both the intermediate and high versus the low tertile. Lower postoperative complications, a lower length of stay, a decreased 90-day readmission rate, specifically in the highest tertile, and lower 90-day mortality in both groups. You had a decreased risk of failure to rescue, and you were more likely to be discharged home. And all of that was in conjunction with having a lower expenditure. So we saw overall improved outcomes in almost all categories with no increase in expenditures. And you can see as you move up in the percentiles, this continues to be true. And that as you have an increasing index, you have an increased risk or an increased odd of textbook outcome, increased odd of being discharged to home, and you had decreased trend towards decreased expenditures. When we continue to look at these and stratify the volume of the hospital between low volume hospitals and high volume hospitals, they continued to be true with increased likelihood of a textbook outcome in both low and high volume. When you looked in low volume hospitals specifically, they also had a decreased expenditure as the index went up. You can see also in the postoperative complications and extended length of stay were both decreased in both low and high volume hospitals. So in conclusion, this care team subspecialization, even within hepatopancreatic surgery, is improved, had improved outcomes in pancreas surgery specifically. as you increase this index, you have an increased risk or a better chance of having a textbook outcome. You have actually a decreased risk of having failure to rescue, and you have an increased risk of being discharged to home, all with having either equal or lower expenditures, depending on the high and low volume hospitals. And this super subspecialization, like for future work, you could imagine that could possibly be in other specialties, like other complicated specialties, neurosurgery, thoracic surgery, et cetera. That would be future work for the group. Thank you. I have questions.
The discussion is Dr. Goptrankau from the others.
Good morning. Thank you, Dr. Dilhoff, and congratulations to you and Dr. Pollack and the group for constantly challenging us to rethink about surgery and surgical outcomes and now surgical practice. I do have a few questions. So here, we tend to think of HPB as a single specialty, but the work here is really raising the question as to whether we should perhaps reframe it as a composite of two distinct kind of subspecialties. So 3 questions, pretty straightforward, I hope, for you. Number 1 is you're showing here that a high pancreatic SSI is associated with a low, with an improved outcomes across the board compared to low SSI, regardless of volume. Do you think that the opposite relationship would be true in other words, a high liver SSI would be associated with improved outcomes compared to a low SSI for liver? Or is there something specific about the pancreas surgery and pancreatic performance, right? Like prehab and enhanced recovery pathways and things like that, that make this true. Number 2, is there a way for you to kind of tease out within the SSI, how much of it is due to the surgeon SSI and how much of it is due to hospital SSI? And then related to your final point, future directions, do you think that this work can be done to, for instance, tease out robotic, right, HPB as an SSI metric? And how will you use this to help patient care in the future? Thank you very much.
Great. Thank you. Thank you for those questions. So your first question was, remind me, I didn't write it. Yes. So can we extrapolate this towards liver? Or I actually think you could probably extrapolate these outcomes towards any other complicated specialty. So I think liver would probably work out to be a very similar outcome when we looked at it. So that's a pretty easy project for us to look at and switch that. So I think that's a good next project for the group to look at. But I think that will hold true. On the how does the hospital interact with the surgeon volume? I think that's an interesting thing to think about. And I think they go hand in hand, surely, right? But I think if you think about, say you have a high volume hospital and a new young partner that comes in, that would be technically low volume for a while. I think your specialization team would still be improved over if you had, a low volume surgeon in a hospital that had low volume. And it's because all of the things that we put in place to help do safe surgery and safe teams. So I think they definitely interact. And I think both are probably in the middle of improvement. So you could probably take the same thing, a surgeon like you, and put you in a rural place with less volume. You're still going to do really well, but not as well as in our high volume systems. As we go on in the future, and I think this has come up several times with our regionalization of care and whether these two specialties are different or should be different. They surely, you can see the picture of as we become specialized, right? This has become more and more and more over the decades. And as we regionalize care, will it make sense to even further specialize within our, HPB specialty? And, they probably got lumped together years ago because of they're both technically demanding and complicated operations. But I think you could make an argument that we all do what we're best at when we, do it over and over and over again. And so I think we could make arguments to further subspecialize, especially as regionalization happens, over the next decade. Thank you.
The hazard ratios were not very high, and your lower confidence interval, some of them, the numbers were 1.01. Were you surprised to not see a bigger impact?
That's a great question. I do think you have a good point, and that I would expect, I think we're probably all biased that we're all specialists and, do really high volume. And so, yes, I agree. I was a little surprised in that it's probably, just a large data set that it's probably not granular enough to see some of those issues and outcomes.
Thank you.
The last presentation is Dr. Benedikt Rumpf from, I can't pronounce this, from Vienna, Austria, on the impact of single nucleotide polymorphisms on chemotherapy-associated steatohepatitis.
Thank you very much, Chairman. Ladies and gentlemen, good morning. My name is Benedikt Rumpf, and I'm a surgical resident from Vienna, Austria. Take a quick look at the work. Yes, it does. Today, I want to talk to you about the impact of single nucleotide polymorphisms in chemotherapy-associated steatohepatitis. But quickly, a quick refresher. Almost half of the patients suffering from colon cancer will develop liver metastases at some point of the diagnosis. One of the main treatment options is, of course, the surgical removal of said metastases. Most patients receive chemotherapy beforehand, either to make the disease more resectable, or in many cases, already resectable patients receive chemotherapy as well. This is a topic that is widely discussed in the last few years, as you all may be familiar with. And although the perioperative management of those patients, the knowledge about the perioperative management of those cases improves over the last years, genetic factors concerning liver health and liver regeneration of these patients may be overlooked. And here I want to talk about single nucleotide polymorphisms. You see, the small change of one base on a gene can lead to a change protein, which may have an impact on the patient itself. There are millions of SNPs that are already explored, and our colleagues from gastroenterology as well as hepatology showed in abundance of SNPs associations with chronic liver disease, non-alcoholic fatty liver disease, and steatosis, fibrosis as well. So some of those SNPs are presented here as well. While the colleagues from hepatology are well aware of the association of certain SNPs with chronic liver disease, the knowledge about the impact of these SNPs in context of liver surgery or perioperative chemotherapy is rather limited. For this reason, we had a patient cohort with intraoperatively taken liver biopsies and genotyped them for those 5 SNPs you see up there. And one SNP in particular piqued our interest. This is a mutation on the PNPLA3 gene, which showed among its genotypes significant differences in the incidence of steatohepatitis. Furthermore, more than half of the patients with a homozygous genotype, who had a homozygous genotype for PNPLA3, showed signs of chemotherapy-associated steatohepatitis. But what is PNPLA3? This is a gene that codes for protein, which plays a role in fatty acid metabolism. The SNP leads to a loss of function, which further leads to accumulation of lipid droplets in liver cells and stellate cells. This facilitates the development of chronic inflammatory responses, further to fibrosis and cirrhosis. So, how do we know that those patients we have here actually have chemotherapy-associated steatohepatitis? Because the association of PNPLA3 and NASH and non-alcoholic fatty liver disease is well established. For that reason, we used a non-invasive method to assess CASH and postoperative liver dysfunction in patients, as already established by Pereira et al. In 2019. It is the combined APRI and ALBI score, which can be calculated using common laboratory parameters. This score is highly increased in patients after receiving chemotherapy could have been used to diagnose CASH in those patients. Furthermore, if you look to the right side, they established a cutoff dividing patients in a low risk and a high risk group, which patients in the high risk group displayed a higher prevalence of CASH, chemotherapy induced liver injury, as well as steatosis. And these patients in this risk group were more prone to post-operative complications such as post-operative morbidity, liver dysfunction, as well as prolonged hospital stay. So we implemented this score in our patient cohort. And you see on the left side, before chemotherapy, this score was not significantly different among genotypes of PNPLA3. However, if you look to the further to the right, the homozygous genotype patients showed a vastly increased score. You can see it all the better on the right side where we calculated the delta. So what we see here is patients who are homozygous for PNPLA3 SNP could be are more prone to liver injury sustained through chemotherapy. We also established the cutoff in this cohort and showed that before chemotherapy, again, no significant differences. Then after chemotherapy, all of the patients who were homozygotes fell into the high-risk group. And to show that the cutoff works in this cohort as well, we could show that this cutoff was associated with post-operative liver failure as well as increased morbidity. So what I want you to take home with that is we saw that PNPLA3, the SNP, is associated with an increased incidence of chemotherapy-associated steatohepatitis. I want you to know that this is not a 1 in a million mutation. In America, especially in the Hispanic community, up to 20% of patients, depending on the GWAS analysis, are carrier of the homozygous risk allele. And this genotyping before therapy could be facilitated by a blood sample. And to close up and circle back to the first slide, there is a discussion going on about neoadjuvant chemotherapy and whether some patients might not benefit from that therapy. From a liver regeneration and from a liver health standpoint, PNPLA3 is in fact could be at least in fact influence this outcome. But we want to see in future endeavors. I want to thank you very, very much for listening, and I'm open for the discussion now.
This paper will be discussed by Dr. Ryan Fields from Washington University.
Thank you. It's great work. I really appreciate you sending me the slides and a big chunk of the manuscript before. And it's really interesting to see, we talk about focusing on the tumor a lot when we're talking about resected colorectal liver mets tumor. And this is really looking at the host and whether we're going to be able to get somebody through it safely. So I just have a few questions and comments. So you talked about one of the SNPs. Big picture, are there other SNPs that you think may have the same ability, either in synergy with this or independently, to look at anything really related to complications, but of course related to liver dysfunction after surgery? And then when we're talking about perioperative chemotherapy, do you think that in this regard, with respect to the mechanism, about that the regimen matters? Meaning, do you think this would be more pronounced in a irinotecan-based versus an oxaliplatin-based regimen, either based on data you have or the mechanism? And then, of course, you hit on it at the end, the idea of can we better select patients for neoadjuvant approach, and say for the homozygous patient here, should we, if we're not thinking about chemotherapy, that's one aspect, but is there a therapeutic intervention that we could do for those patients that are homozygous, say for this, that would potentially, based on, again, the mechanism or what reduce the chance of them having dysfunction? And then for patients that are positive for this, especially homozygous, are there any
surrogates for that you can see, say radiographically on MRI or anything? And I guess what I'm getting at is really kind of this idea of radiomics. We use what we know from what you've shown us, that we can stratify patients even more based on how, say, their preoperative MRI looks or anything like that. Again, incredible work. I think this is kind of where the future is molecular, to try to best select the right patient for the right treatment at the right time. Congratulations.
Thank you very much. And thank you for the questions. I try to answer them in order. Concerning other SNPs, yes, there are in fact other SNPs. There is actually an abundance of them. However, the PNPLA3 RS738409 SNP has the closest association with chronic liver disease. You're completely right. There are studies concerning the amplification of the effect of the development of non-alcoholic fatty liver disease, in which they, for example, did a GWAS analysis and showed that if patients were positive for more than one SNP, that the effect on the development of steatosis was in fact amplified. However, a much larger sample size is necessary to see the effect sizes of those combinations. The second question, if the chemotherapy regimen does matter, it is only intuitive to think about, for example, irinotecan based therapy, because we know literature indicates that most of CASH is facilitated by irinotecan based chemotherapies. Yes, we could not see that in our patient cohort, however. PNPLA3 stayed a significant parameter for the development of CASH. Then here again, a larger sample size would have been of greater use. And the last one, there is literature concerning the number of G alleles or risk alleles in PNPLA3, and there have been association with heterozygotes as well. And as you could see in the previous slides, there is a gradual increase. However, the homozygous genotype has the most increase compared to the other two genotypes. So probably if you want to screen patients with the data we have, it would be most useful to screen for the homozygous genotype. And the last question, if there is any possibility to screen for preoperatively for this SNP with MRI with imaging, there has been an elastography-based study which correlated the PNPLA3 SNP with increased steatohepatitis. However, since we don't know if this steatosis we saw there, it does affect post-operative or post-therapeutic outcome as well, it would be more useful to genotype the patients beforehand. But then again, there's a lot of research that has to be done in this manner.
Paper's open for discussion.
Hi, John Travenko from Montreal, McGill. Question about metabolic syndrome, which drives NAFLD NASH. Did you control for that in your cohort? And the second question is, a lot of literature suggests that type 3 immunity is important in NASH, primarily ILC3 innate cells in the liver, which reside in the liver, and through the IL-17 pathway induces NASH and cirrhosis and fibrosis. Did you do any immunological studies? And did you account for that?
For the last question, for the interleukin 17, we did not do studies on that. but I am familiar with genetic variations on that gene. We excluded this at first because the first screening we did showed a more protective effect of those SNPs. And the first is, yes, you are right. Metabolic syndrome facilitates NASH and steatohepatitis. However, in our data, this didn't play that much of a role actually. So PNPLA3 was the most significant parameter in our cohort.
Okay, thank you to our presenters, discussants, and audience. Oh,
Hello, my name is Martin.
I've met some of your colleagues at the SSAT, right? Because there's a SSAT chapter. Morning in Mexico. There's a SSAT chapter in Mexico.